Hi, my name is Dr. David, neurosurgeon specialized in pain management. Today's topic is rotator cuff tear. Rotator cuff tear refers to the tear of Supraspinatus, Subscapularis, teres minor, and Infraspinatus that make up the rotator cuff. It can be divided into degenerative rotator cuff tear caused by natural aging and traumatic rotator cuff tear by injuries, which mostly occur in young people. Degenerative rotator cuff tear is the main cause of shoulder pain in patients over 45 years old and account for about 2/3 of the cases. Rotator cuff tears can be divided into partial tears and full thickness tears. Partial tears can be classified as bursal side tears, articular side tears, and intratendinous tears depending on the location of the tear. Full thickness tear refers to tears that connect the bursal side to the articular side rather than the size of the tear. Degenerative rotator cuff tears usually do not occur before the age of 50, mostly occur in one side in the 50s and 60s, and mostly occur in both sides in the 70s or older. About 20% of people in their 50s and 60s and 80% of people over 80 years old have asymptomatic rotator cuff tears. Rotator cuff tears are more common in men and middle-aged manual workers and are more common in the right shoulder for right-handed people. The causes of rotator cuff tears are trauma and degeneration. Traumatic rotator cuff tears are caused by severe trauma, while degenerative rotator cuff tears are caused by various factors. The causes of degenerative rotator cuff tears can be divided into external causes, which are caused by environment around the rotator cuff, and internal causes, which are caused by rotator cuff itself. Neer proposed that rotator cuff tears start on the bursal side of the rotator cuff. He explained that when the rotator cuff passes through the narrow subarachnoid space due to disease, impingement occurs between the bursa and the rotator cuff, and tears start on the surface of the rotator cuff. This theory states that when the arm is lifted forward, the anterior rotator cuff hits the coracoacromial arch, causing impingement, syndrome, tendinopathy, and tears. Neer proposed that rotator cuff tears start on the bursal side of the rotator cuff. However, it has been established that in many cases, rotator cuff tears occur from the articular side. This cannot be explained by Neer's theory alone. Cotman explained this phenomenon as that tears start from internal impingement caused by repeated collision of the labrium and the deep surface of the rotator cuff tendon. The starting location of rotator cuff tear is generally 1.5 cm posterior to the biceps long head tendon. This location is where supraspinatus and infraspinatus overlap, also known as rotator crescent, which is a thin area of rotator cuff tendon that has poor blood supply, making it a critical zone, and where rotator cuff tears are known to occur usually. Rotator cuff tears can cause fatty degeneration of the rotator cuff muscle and fatty infiltration of the tendons. The more severe the tear is, the more fatty degeneration of the muscle occurs, especially the front part of supraspinatus tendon and the infraspinatus tendon. There is no correlation between the degree of pain and the degree of rotator cuff tear. The progression of tear is considered a risk factor for pain. A study of 50 patients with full thickness tears found that 36% developed symptoms, had larger tears, more muscle degeneration, and abnormal findings in biceps long head tendon. Tears less than 10 mm do not cause significant functional problems in the shoulder, while tears greater than 20 mm cause muscle degeneration. Full thickness tears do not heal well in non-surgical treatment, and 74% of patients with full thickness tears develop cuff arthropathy. compared to 7% of patients with partial tears. The progression of tears varies depending on the study, but is estimated to be between 0.5 to 4 mm per year. X-ray examination can reveal subcondylar sclerosis and bony spur on the shoulder joint, which can suggest rotator cuff tear. Ultrasound examination can diagnose the degree and location of the rotator cuff tear, as well as the degenerative changes of other structures. It can play an important role in determining the treatment options and can also show the progression of rotator cuff tear. In ultrasound examination, a full thickness tear appears as a low echogenic defect, and fluid can seen in tear area, making a tear more visible. If there's no fluid, a deltoid muscle can be observed above the joint cartilage. Partial tears are mainly located on the articular surface of the rotator cuff muscles, located on the superior anatomical neck of the humerus. On ultrasound, partial tear can appear as clear hypoechogenic or a mixture of hyperechogenic and hypoechogenic image, and the same findings should be seen on both short and long axis ultrasound image to rule out anisotropy. Non-surgical treatment is done for tears that are not suitable for surgery, patients who are not in a condition to undergo surgery, or those who do not want surgery, and small partial tears. Subacromial subdeltoid injection of corticosteroid is an effective treatment for pain caused by rotator cuff partial tears. About 0.5% of lidocaine is injected, and triamcinolone can also be injected together. It is also effective in full thickness tears, but there is concern that it may further progress the tears, so it is injected very carefully. The decision of surgery is based on the patient's age, the size of tear, and the degree of muscle degeneration, but there are not many cases that require surgery. So this is all I prepared today, and if you have any questions about rotator cuff tear, please write a comment below and I will do my best to answer the question. Thank you for listening. Goodbye.